Hello there, my name's Tom Hampton. I'm a final year student and I'm going to be talking to you about neurology. And this is essentially just a primer, an introduction to neurology to help you all think about different ways of thinking about neurological problems as they present. The first thing I think we should do is have a look at what we're talking about when we're talking about neurology. So you've got the CNS, everything in your head. And then you've got the peripheral nervous system. As you know, there's autonomic and somatic roles. So the GI system has the most nervous tissue of any organ in the body. And you also have the peripheral nervous system's responses to vasculature and also respiratory. Think about the diaphragm. And then we have the motor and sensory functions that we use every day. And what exactly is involved in all this? Well, let's think about the cells. So we've got neurons and we've got glia. Now neurons, we've got the white bits and the grey bits, if you've ever seen a cut-up of the brain. So the white bits, that represents the axons. Axons are white because they're surrounded by myelin, which, as you remember from your first year days, is enabling them to conduct a little bit faster, the impulses. Whereas the grey bits, that represents the actual cell bodies of the neurons. And then we have the glia. There's four kinds of glia. There's astrocytes, which look exactly like it says on the tin. Astro meaning stars, so they're star-shaped. They've got little branches that touch the capillaries, providing membranes for support, and they're essential for the blood-brain barrier. And if you were to stain them, they're positive for GFAP. And then we have oligodendrocytes. These are little circles, small and round, and their role is to make and also to maintain the myelin we spoke about earlier along the axons. And then we have ependymal cells. These are columnar. They're responsible for producing the CSF in the brain, and they line the ventricles. And then finally, we have the microglia, which act as the brain's resident macrophages. Now, they're actually bone-derived, but then they stay within the brain, within the blood-brain barrier, and they respond to injury and have innate and adaptive responses. And when they're activated, they become ramified. Now, let's think about how the brain is arranged. Now, I'm sure you've seen pictures of the 6 layers of the cortex. I think it's probably more useful, rather than going into the very finite details of all that, to think about our old friend, the homunculus. Now, in the homunculus, you've all seen that picture with the mouth and the foot, and it's all wrapped around the brain, but I think it's more useful to think about it like this. Imagine, if you will, the famous statue, Rodin's Thinker. It's that scholar who's struggling with some particularly tricky task at hand. And, well, let's be honest, neurology isn't the simplest of topics, and you know, maybe you should rest your elbow on your knee and have a little think about it yourself, and things might come to light. So there you are, imitating Rodin's Thinker, with your hand against your chin, your elbow on your knee, and that's how the homunculus works, really. Well, that's the best way I thought to think about it. So there's my patchy diagram on the bottom left. And what you need to do is think about, from laterally, mouth, head, hand, arm, leg. If you think about Rodin's Thinker, so your thinking starts in your feet, goes all the way up your leg, into your arm from your knee, onto your hand, then hits your chin, representing your head, and then finally it goes into your mouth, and you've got to talk about what you've actually thought about. If you find that a little bit patronising, there's a few other ways we can think about this. So let's talk about different sieves for differentiating what's going wrong. One thing that's useful in neurology, especially, is a temporal sieve. Now, we've got seconds, minutes, hours, days, weeks, months, and years. If something happens, let's say dead fast, something happens instantaneously, for instance a stroke, there you are, you're thinking about vascular things. If something happens in a couple of minutes, maybe, someone's feeling a bit groggy, and then, hits the deck, well, you're going to be thinking more about metabolic things, like maybe a DKA. If you're talking about hours, or maybe even a few days, something taking place over a relatively long amount of time, you're thinking more of infectious causes, with bacteria being slightly speedier than viruses and fungus. If something's niggling for a couple of weeks maybe, then you're thinking more inflammatory causes. And when we move on to chronic periods like months, I've had months of weight loss, I've been feeling under the weather for months, it's been months since I've been able to get a good night's sleep, well then you're thinking more sort of malignancy than neoplasms. And then finally, over years, you have the degeneration of conditions such as the neurodegenerative, Parkinson's, Alzheimer's, things like that. Going back to a more conventional surgical sieve, that's another option. Now, my favourite surgical sieve, as pains me to admit, is Vindicates Me. If you're even struggling after that, you can add a pretty please and add physiological and psychological, but let's start with the most important, shall we? So we've got vascular, infective and inflammatory, neoplasm and degenerative. I'll talk about those a bit more later. And then you have iatrogenic, which, as you know, means things like drugs, surgery, radiation, maybe the odd mistimed lumbar puncture. Congenital, autoimmune, which accounts for things like SLE, but specifically in neurology, think about the demyelinating autoimmune diseases like MS. And then you have trauma, which does what it says on the tin, endocrine, structural problems, and then the metabolic, that's thinking of obviously glucose, alcohol, carbon monoxide, vitamin deficiencies. And then by physiological, I mean things like pregnancy, or sort of appropriate stress responses. And by psychological, I'm thinking of the conditions which cross over into neurology and psychology as well. So let's look at those big four. So vascular, we're thinking strokes, basically. You can have ischemic or hemorrhagic strokes, and also the effects of hypertension. When we think of infective, you can have localized for an abscess. You can have across the brain, so encephalitis, or you can have within the meningeal tissue, so meningitis. Additionally, in there we've got the novel disease mechanism of prions, which is your CJD, mad cow disease. When it comes to neoplasm, most commonly it will be metastases that we're thinking about. But there's also several primary CNS tumours. Most commonly, the metastases are secondary from breast, lung, kidney, and malignant melanoma. And the primary tumours are made from the glial cells, so either an astrocytoma or an oligodendrocytoma. When it comes to all brain syndromes, there's obviously the option of there being a familial syndrome, such as neurofibromatosis or tuberous sclerosis, and several others as well, which often have multiple interactions in other kidneys and livers and other organs around the body. And finally, degenerative. When I'm talking about degenerative, it's important to subcategorize into three sort of pathologies, if you will. There's cortex, ganglia, and motor neuron. So things that affect the cortex are Alzheimer's disease, frontotemporal dementia, and vascular dementia. And things that affect the ganglia, so that's going to affect your movement. So you've got Parkinson's, because you have your shuffling gait, if you remember, multiple system atrophy, and Huntington's with its classic career-form movement. And then finally motor neuron disease, including amyotrophic lateral sclerosis and SMA. Now, when we're thinking about things going wrong, another important way we can think about the brain, so we've already thought about a temporal sieve, we've already thought about the homunculus, and we've already thought about the traditional surgical sieve. In the brain, you can think as well about anatomy. So, let's think about the vascular supply to different anatomy. Now, again, from this evidently hand-drawn diagram, you can see I've drawn in the brain and a few of the artery supplies. So, supplying the frontal lobe, we've got the anterior cerebral artery, and then we have the middle cerebral artery, and finally the posterior cerebral artery. Now, the internal carotids both supply the ACA and the MCA, and the vertebral arteries both supply the basilar artery, which then becomes the posterior cerebral artery. Now, after many hours in front of books, diagrams, lecturers, and neurologists, I believe that this is the simplest way to think about areas of loss and neurological signs in terms of their anatomy and blood supply within the brain. So, this is going to require remembering the homunculus and also that previous slide on the blood supply. So, let's say you have a patient who comes in with some decreased strength and loss of sensation in their leg. Well, we know from the homunculus that that represents the portion of the brain, if we have a coronal slice, that is closest to the central sulcus, and we know that the supply to the area of the brain that is that involves central sulcus is the anterior cerebral artery. So therefore, if someone has decreased strength and loss of sensation in their leg, then that's as a result of a blockage or problem in the anterior cerebral artery. By the same token, if they have decreased strength and loss of sensation in their upper arm, or upper body in fact, so arm and head, then that represents the areas of the brain supplied by the middle cerebral artery, as you can see from this diagram. Whereas, finally, there's only the small bit at the bottom of the brain supplied by the posterior cerebral artery, and if someone has visual loss, or dizziness, or ataxia, that's as a result of a problem with the posterior cerebral artery. So, let's just summarise that again. Anterior cerebral artery, central sulcus, is the central sulcus, and that represents the leg. Middle cerebral artery represents the lateral sulcus and the loss of strength or sensation in the upper body, so arm and head, and then the posterior cerebral artery will indicate visual loss or dizziness and ataxia. There are several signs and symptoms which are associated with neurology. I won't go into too many details, but classically you'll have someone complaining of a headache, and if you have a headache, you need to think about intracranial versus extracranial causes, and this is covered by other podcasts. And if you have neck stiffness, that's another common complaint, so you can think about meningism or possibly osteoarthritis. If you have loss of consciousness, and there's several possible causes, it could be metabolic, to do with hypoglycemia or ketoacidosis, liver failure or drugs. It could be a brainstem problem involving an infarct or a hemorrhage. Now, traditionally, these brainstem hemorrhages are a result of a Charcot-Bouchard lesion. Or it could be cerebral, so that would involve an infarct or a hemorrhage again, additionally infection or trauma affecting cerebral cortex. Then we have dementia and those sort of symptoms that people get with dementia. So that's people complaining of deficits across several of the cognitive domains, which I'll go into in a second. And the causes of dementia can either be ischemic, toxic, or neurodegenerative. Then we have epilepsy and the associated fits of epilepsy, and these can be either idiopathic, or occasionally they can be because of unusual conduction due to a focus of disease, altering the way the electricity is conducted across the brain. So thinking about a stroke or a intracranial lesion, such as possibly a cancer. Then we have things that affect the reflexes, so either upper motor neuron or lower motor neuron lesions, affecting the reflexes on examination. And then we have things that affect the muscles. So the muscles can either be wasted, terribly weak, or they can be hypertrophied, compensating. Then we have paresthesia. So, for instance, when you're doing your examination and you spot areas of sensation loss, such as classically the diabetic glove and stocking. And then vision problems, which is fairly specific. So the individual could have cataracts, they could be suffering from problems, again, of diabetes, sort of metabolic. They could have a problem with hypertension, or it could be a tumour within the brain pressing against one of the cranial nerves. And finally, we have hearing problems. So this could be due to impaired transmission. It doesn't have to be a nerve problem. It could also be a simple obstruction, such as wax, or it could be a specific lesion to cranial nerve 8. Now, I briefly mentioned earlier the crossover between neurology and psychiatry. Very scary. Now, the big things that tend to confuse students, especially me, is the two sort of syndromes that tend to cross over the psych and the neuro. So dementia, which we understand is a neurological problem, is defined as this progressive deficits across several cognitive domains, as I previously mentioned. Now, the causes of this, we'll just go into a little bit further. So we have Alzheimer's, vascular, Lewy body, degenerative, metabolic, infectious, and other. Now, Alzheimer's is 50% of the causes of dementia, or that's what it represents. And so if we think about those progressive deficits, they're going to be in things like decreased memory, poor executive function, aphasia, which means language, apraxia, which is to do with motor tasks and sort of fine details, and agnosia, which is the traditional Auntie Jess forgetting names and name recognition. So they've got this global impairment of their higher mental health, but remember, it has to be in clear consciousness, and that's when you differentiate between dementia and delirium, and I'll cover that in the next slide. So Alzheimer's, as I said, represents 50% of the dementias. It tends to be in the elderly. It just represents atrophy of the cortex and hippocampus. You'll get dilated ventricles. And you have amyloid plaques, neurofibrillary tangles, and tau proteins. It's got associations with Downs, commonly at the age of around 45, and that's to do with a trisomy 21 that causes the Downs, meaning an increased number of APP, which is on that particular chromosome, and that leads to the A beta causing the amyloid. Then we have vascular, which represents around 20% of dementias, and that's your stepwise plateauing picture. So grandpa is doing fine, and then he has a sudden deterioration, and then he sort of carries on at that level for a bit, and then sudden deterioration again. You sort of each stepwise decrease representing multiple small infarcts. The dementia with Lewy bodies, which obviously has a crossover with Parkinson's, that represents about 5%. So, as it says, you've got your Lewy bodies, you've got some neurofibrillary tangles. Classically, the hippocampus is spared, so it's less memory. It's actually a little bit of fluctuating cognition, but specifically, as well as the Parkinson signs, the other idiosyncratic thing to dementia with Lewy bodies is visual hallucinations occasionally. The other degenerative things that it could be represents PICS, which is frontotemporal, and Huntington's, which is the familial autosomal dominant career form syndrome that we all know. Metabolic causes, as we've already said, alcohol being a specific cause, and infectious causes, we're thinking about variant CJD and also syphilis in the tertiary stage. Other causes include things such as tumours leading to deranged function and the motor neuron disease. So that was a bit of a mouthful, but now we're on to delirium, which is a globally impaired cognition with impaired awareness and consciousness. So it's not necessarily that they're not aware of what they're doing, it's more that they're completely out of it. So if it helps to think about this, let's think about the causes. So drugs, and when I say drugs, I also include alcohol. So people that aren't really with it 100%. Then you've got changes in electrolytes. Lack of drugs, say for example if a person is usually on a particular agent and then that's been removed. Infections causing a sepsis. You also think about UTIs and your elderly patients causing aggro on the wards because of an untreated UTI. Reduced sensory input, and this is what accounts for both med students and patients alike. If you're starved of sleep and you're in the dark, you often think you see things, and that represents an element of delirium. That's just because you don't have sufficient sensory input for your brain to decide what's going on. Then you have intracranial causes, things such as urinary or fecal retention, and finally heart attacks, or sometimes even just common pneumonia. Now, let's get a simple table up to help us differentiate between these two. So the two Ds. Onset. If I'm demented, that's going to be something that's insidiously occurred. So you're thinking about your old Auntie Mabel, your old Uncle Pete, slowly losing his mind. Delirium, that's something that's acute, that's insidious. So it's something that's happened just, if Auntie Janet is, really with it, in charge of the Women's Institute, and then suddenly the next morning she's really completely off with the fairies, well, then you're thinking more delirium than dementia. Early course of the disease in dementia will be this sort of constant increase in symptoms, so generally they'll be the same from one week to the next, whereas in delirium this is something that's fluctuating, because it's dependent on things, as I mentioned, such as the light and sensory input. Attention. So in dementia, generally the individual is sort of with it. They can give you good attention, they can follow you to some extent. But in delirium, you won't really get a good interaction with the patient because, as I said, you just need to think about them being sort of out of it and not really in clear consciousness, I think is the specific statement. And then we come to the delusions and hallucinations. So these are less common in dementia, but it's something that will really help you pick out someone who's delirious. Someone seeing things in the dark, someone, they'll be simple and fleeting, but they are quite common, these sort of delusions or hallucinations in delirium. Now, the final way that I haven't really mentioned of thinking about neurological problems is the pathological sieve. So if you prefer to think about the pathological processes that are going on, so space-occupying lesions, so that's going to be things such as herniation, edema, hydrocephalus. Or we can think about malformations or perinatal injuries in children. You can think about the problems caused by trauma, so that's obviously physical damage to the skull or the vasculature or even the spinal cord. In stroke, remember there's a few different causes, so it could be ischemic, it could be hemorrhagic, it might just be due to raised blood pressure. And then you have your infections affecting different areas of the brain, whether it's localized or more general. The demyelination processes of multiple sclerosis and edema. Degenerative, as we've already mentioned, differentiating into cortex, basal ganglia, and motor neuron focus problems. The neoplasms, as we mentioned, being primary, secondary, and familial. And then metabolic, so glucose, alcohol, carbon monoxide, and vitamin deficiencies. So, I hope that's all come together a little bit more for you now. So what did we talk about? We spoke about the role of the brain and the CNS and the peripheral nervous system. We spoke about the individual cells that were involved, neurons and the glial cells. We spoke about the homunculus, which is a useful way of considering the arrangement of the brain representative of sensation and motor around the body. Remember Rodin's thinker. We looked at several different sieves, so the temporal sieve, which is very useful for the onset of symptoms, pathological sieve at the end there, thinking about different disease processes, and the speech-marked surgical sieve, i.e. the traditional way of thinking about things in terms of different causes, and we used Vindicate Me. Anatomy, that was just again looking at the anatomical supply and correlating that with the homunculus. A few of the signs and symptoms that you might come across, and then the psychiatric overlap with dementias and delirium and differentiating between the two. Okay, so hopefully that's primed you up and you're ready to go, and have a look at a few of the other podcasts which deal with some of these symptoms and syndromes in more detail.